Hello and good evening. My name is Dr. Reed Tuckson, and I have the honor of being a co-founder of the Black Coalition Against COVID. The Black Coalition Against COVID has been operating now for 18 months, solely dedicated to fighting this pandemic in every way that we can. We are a community-based grassroots organization in Washington, D.C., and we are also a national organization comprised of our 4 historically Black medical schools: Howard University, Morehouse School of Medicine in Atlanta, Meharry Medical College in Nashville, Tennessee, and Charles Drew University in Los Angeles, California. We're also the Black Medical Society, the National Medical Association, the National Black Nurses Association, and to this firepower of all the leadership of Black medicine, we're also the National Urban League and the organization that's helping us produce this event tonight, blackdoctor.org. We are all united in our belief that all lives matter. We definitely believe that Black lives matter, and we are united in our belief that the lives of incarcerated people matter. We understand we have an obligation to make the conditions inside of prisons and jails and other settings of confinement more humane and less inhumane, especially in this COVID pandemic. We realize there are 2 million people at least living in these institutions, and we have to do our work for their sakes, for their families, and the communities to which the overwhelming majority of them will return. We truly are all in this together. The lethality of jails and prisons during the pandemic was underscored for us by an article in the Journal of the American Medical Association, which indicated that the infection rate for COVID-19 was 5 times higher among state and federal prisoners than among the general population, and that incarcerated people with the virus are much more likely to die than non-incarcerated people who are infected. We cannot simply read these words and not be compelled to action. That's why we're joined tonight by many of the most engaged, experienced, and wise advocates who bless our nation with their advocacy. Tonight, we're going to cover a lot of ground. If you're interested in examining this issue from the perspective of those currently incarcerated, we have the experts for you. If you're interested in examining the process of transitioning from an institution and returning to the community, we have the experts for you. If you are a member of an involved family and you have questions about vaccination for yourself or your children, whether or not your kids and how they can safely return to school or participate in youth sports, we have the experts for you. And finally, at the end of our show, leading health officials will summarize what they heard tonight and identify some of the issues that they will place higher on their radar as a result of tonight's discussion. Please feel free to raise your questions, particularly about vaccination or masks or any other element of protecting us from this COVID pandemic in the chat. But please be aware that there will be young people listening in tonight. So let's use a little common decency and decorum in how we conduct ourselves in the chat room. Well, let me introduce 2 people to welcome us. Number one, Jay Butler. Jay Butler is a senior level official from the Centers for Disease Control and one of the most important people who is leading the charge against COVID. He's the Deputy Director for Infectious Diseases at the CDC, where he provides leadership to the CDC's efforts across the board in dealing with infectious disease priorities. Jay Butler, please take the microphone.
All right. Well, thank you, Dr. Tuckson, and good evening, everyone here, also in Washington, D.C., just probably down the street from Dr. Tuckson. So I want to take the opportunity to welcome you on behalf of the Centers for Disease Control and Prevention, and thank you for taking time to be here tonight to have this important conversation. Early in the pandemic, I remember hearing someone on one of the cable news networks talking about how this pandemic would be a great equalizer because we would all be at the same risk. But unfortunately, I think all of us know that that simply isn't true. And in fact, this pandemic has shone a bright light on the health inequities that have been experienced in our nation for decades and centuries. So as we think about the fact that, no, we're not all in one boat, we're all in different boats in the same storm, how do we help one another to be able to survive? And the focus tonight is on people who are incarcerated or otherwise involved with the criminal legal system, and how do we best help people to be able to protect themselves from the impact of COVID-19, no matter who they are, white, Black, incarcerated in the community. So I look forward to listening tonight more than speaking, hopefully being able to answer some of your questions and being able to engage with you. Thank you, Dr. Tuckson, for the opportunity to be here tonight.
Thanks so much, Dr. Butler. We appreciate it. And now let me introduce Roach Brown. Roach Brown is an activist, a writer, a radio personality who at age 20 was convicted of murder and received a life sentence. While in solitary confinement, he wrote a poem in the dust under his bunk called Christmas in Prison. That poem evolved into a play called Christmas in Time, and the Inner Voices drama group was formed. After 500 performances outside the gates of the Lorton Reformatory on Christmas Day, 1975, Roach Brown received a presidential commutation from then President Gerald Ford. Welcome, Roach Brown.
And Merry Christmas to you, Dr. Tuxton. Thank you for inviting me to be a part of this, and thank all of you who are listening and joining in. This is an opportunity that we've been hoping that we can get this word out for the past 18 months or a year. My wife and I on our radio show have been pushing this issue about COVID-19 because 1 in 5 inmates inside have the COVID-19. Over 4,000 men and women have died. And since the advent of this deviant that just came down, the death rate has been quadrupled from January of last year, from May of last year to this year. The average death count daily is 1,500 people dying per day, and the numbers are frightening inside the institution. As Doc said, I was inside a prison. I had life. I came out, and for the past 2-3 decades, we've been working on improving the conditions and the situations for men and women going in and those coming out. And the bottom line is this COVID-19 has created a catastrophe within a catastrophe on top of a crisis. This is an emergency, folk. We have men and women and youth who are dying in these close confines, like the inmates down in Texas. They don't have air conditioning. And it's out of 16 prisons in Texas, I think only 2 or 3 may have air conditioners, and men have died from heat stroke. On top of that, here come the COVID-19. On top of that, come all these other issues. You're cut off from your family. They got prisons now where somebody's been diagnosed with COVID-19. They're isolated, supposedly inside a prison. They're already isolated. Then we tried to conduct a survey and found that out of all the more than 6,000 prisons and jails in America, not one have a respirator or ventilator inside the institution. Not one. The Federal Bureau of Prisons, during this major COVID-19, which has affected the whole world, the chief medical officer does not have any medical degree, background, or experience or expertise. The top 4 people inside of the Federal Bureau of Prisons Medical Division do not have the proper credentials or qualifications. And this is a problem that's all over the country, not just the Bureau of Prisons. You find people in capacities inside institutions who are giving them jobs because of their relationship or association or whatever, and they don't fit the criteria. So this issue about getting out information out about the COVID-19 is really, really something. And as you know, there's always a profit margin in everything. And in this, there's a profit margin. And the profit margin is that when those people being released on COVID-19 or for compassion release are placed on electronic monitoring, and somebody is providing those electronic monitors. And it's been reported all over the world that all the prisons who've been released due to the COVID-19 have been placed on electronic monitoring. And the companies that own this and conduct this business are making millions. Who would think you make this kind of money within a pandemic? And in closing, I just want to say that I did an article about 2 guys. One did 50 years and one did 48. And this is one of the things that got me and Dr. Tuxton has been really pushing on. The guy did 50 years in prison and had stage 4 cancer. And they released him without no medication, no pain pills, no referral to a medical facility, no nothing except the clothes on his back and no place to stay. And if he didn't have friends to call to come to his aid, then another gentleman came out who did 48 years. He just come out. I put him in the car and I said, "Man, put your seatbelt on." He said, "What's a seatbelt?" He didn't know what a seatbelt was. So I showed him and whatever. Then I said, "Why didn't you call me? You've been out." for 3 or 4 hours. You could have called me and said he walked and he walked and he couldn't find a phone booth. So besides the social and the mental and the psychological issues, this whole acclimation or adjustment, cultural shift, change, this whole psychological piece has to be dealt with because you got people like who've been asleep in a in a prison or catacombs for 3, 4 decades, and they probably try to hope they will survive or just out there. I close and wrap up, but please take this issue seriously. Our men and women are dying inside this prison, and they need to know that we care and we can do something about them. Because not only the men inside, they got families, they have kids, grandkids, great, and they want their grannies and their grandpas back there with them. So remember, there but for the grace of God, go I.
Oh, Roche, you've set the table just perfectly, and thank you so very, very much. Well, to frame the context for our discussion, let me just remind everyone of where we are as a nation. We are now at more than 38.8 million confirmed cases, more than 637,000 deaths. Around the world, 4.5 million deaths. We know about this Delta variant, which is so unfortunately good at doing what a virus like this is designed to do, which is to kill people. This Delta variant has become very smart at killing human beings. And we now have to be so concerned about not only that one, but other ones. The 7-day average of new cases on Monday was more than 300% higher than Labor Day of last year. And there has been a real jump as a result in the number of people that are in our hospitals. There are multiple states around this country now that basically have no ICU bed capacity left, no intensive care unit beds left, or any other beds in their hospital. There are now reports of people in many of our states who literally are dying from other diseases or emergencies because there's no bed for them. For the Native American, Black, and Hispanic community, we continue to be disproportionately hospitalized with COVID-19. And it's growing fastest in terms of hospitalizations among Black people across 99 counties in 14 states where the CDC collects its data. We have 175 million people fully vaccinated. That's the good news, 53% of the population. Unfortunately, the bad news is we have only 53% of the population vaccinated. We know, though, that there have been, again, 175 million people who have gotten full doses. So we know the vaccines work. We know that they are safe. We know they're effective. And maybe tonight we will talk some of the issues about mandates and boosters and the importance of masks. But before I turn over to our panel, because Roach did talk about children, and this conversation is very much also about our kids, remember, 500,000 children tested positive for COVID in the United States between August 5th and August 26th. In the last week alone, 252,000 children in 1 week. And we now know that 2,400 children are being hospitalized in the United States now. And between August 20th and 28th, an average of 330 children admitted to hospitals every day. Since late July, 1,000 schools across 31 states have closed. So we have some real challenges here. Well, to get to our panel and discuss some of these issues, I'm really, really glad to introduce first Liesl Hagen, epidemiologist for the CDC COVID-19 Corrections Unit, an acknowledged researcher and expert in how to handle COVID-19 in correctional and detention facilities. Dr. Homer Venners, former chief medical officer for New York City's jail system, current member of the Biden-Harris COVID-19 Health Equity Task Force, and the author of Life and Death in Rikers Island. Ed Hayes, assistant superintendent, director of treatment, Franklin County Sheriff's Office, where his goal is to support each individual offender's successful reintegration into the community upon release. That work toward reentry begins on an inmate's first day of incarceration. Dan Mistak, director of healthcare initiatives for justice-involved populations at the Community-Oriented Correctional Healthcare Services. In that capacity, he connects community systems of care to improved healthcare beyond the walls of the jail, including at reentry. Really pleased that Deanna Hoskins could join. She is the president and CEO of Just Leadership USA. Just Leadership USA empowers people most affected by incarceration to drive policy reform. Formerly, she was the senior policy advisor over corrections and reentry, with the Department of Justice. She is herself a previously incarcerated individual who has successfully transitioned back into the community, ultimately receiving a pardon from Governor Ted Strickland. Tracy Gardner, as the Legal Action Center Vice President of Policy Advocacy, Tracy spearheads major initiatives and fosters strategic partnerships that support the Legal Action Center's mission focused on policy advocacy in the justice and health arena. From 2015 to 2017, she also served as an Assistant Secretary of Health for New York State. Felicia Henry, Director of Research and Policy, Correctional Association of New York. Her research interests include race, ethnicity, gender, criminal justice, and mass incarceration, and much more. Previously, she was Program Manager for Diversion and Reintegration at the New York City's Mayor's Office of Criminal Justice. And finally, Shelley Solomon, President of Children of Inmates, where her work reconnects children to their incarcerated parents, creates positive memories and moments for children, and facilitates rebuilding lasting bonds for a lifetime. We're very, very glad that all of them are with us, and Roach will also stay on with us. And I'm asking Jay Butler to be available for any of the medical questions that will come up in this section. Well, let's begin with you, Liesl. We've given a few of the statistics out, but tell us really, so many of us think that jails are like a black box where no light escapes, that we don't see transparency. What do you see as the key statistics that we need to remind ourselves of tonight?
Thank you so much, Dr. Tuckson, for putting this together and for the opportunity to be a part of this panel. As you said, data are extremely important for us at the CDC in order to make evidence-based guidance. And so we've been working for the last 18 months to make sure that we have good data on COVID in correctional facilities. But it's a lot harder than you might think to get complete and accurate data from correctional facilities for a lot of different reasons. And many folks on this call may be familiar with the structure of corrections, but for those who may not be, you have local jails that are administered at the county level or at the city level if they're municipal jails. And then you have state prisons and you have federal prisons, and you've got immigration detention and juvenile facilities. And so there are really a lot of different types of settings. And each of these different settings collects and documents their data on COVID in different ways. And there's really not a nationally coordinated data reporting system for COVID in corrections, or really for any diseases within corrections. And that's been one of the challenges for getting comprehensive data during the pandemic. There's so many institutions across the country, over 3,000 jails, and state prisons and federal prisons just makes it very hard to get all that data into one place in a similar form. So the ways that we generally get data are from asking state health departments for data from their jurisdictions. And then there are also organizations that scrape data from publicly available websites. And one of those is the UCLA Behind Bars project. And that particular project is funded by CDC as well as other entities in order to bring data together from a lot of these facilities across the country. And so based on their data, what we're able to see as of today is that there have been more than 422,000 cases of COVID among incarcerated people across the country, and almost 3,000 deaths among incarcerated people. Among staff, there have been almost 111,000 cases and about 200 deaths. Now, you'll notice that the numbers that I just gave are actually different than the ones that Roach gave. And I think that illustrates some of the challenges that we've been facing in getting data reported from all of these entities in a systematic way. So that is a challenge we continue to face, and we're working with partners to collect data in a more systematic way. And there are really also two important things that are missing from the data that we have. One is data on mental health. And we know that COVID has devastating impacts on people's physical health. But one of the things that's hidden behind all of that is that a lot of the mitigation measures that are recommended, really they take their toll over time on people who are incarcerated. The pandemic has been hard for everyone, but just imagine that you're isolated away from your friends and family, and you're quarantined for a long period of time, or you have to wear a mask 24 hours a day. All of those things end up having a very negative effect on people's mental health. And that's something that's even harder to capture in the data that we see. And another thing that's missing from our data is information on race and ethnicity. And although we recognize and we realize that these are extremely important data to have to make sure that we're reaching the people who are at highest risk of getting COVID and highest risk for dying from COVID, Data on race and ethnicity simply aren't reported to CDC in a systematic way. And so we end up doing small projects where we request these data from a limited number of facilities. But what we do know is that communities of color are disproportionately affected by COVID-19. I don't think that's news to anybody on this broadcast. And we also know that communities of color are also disproportionately affected by incarceration. And so it's that intersection that makes incarceration such an important conversation and such an important area in terms of health equity.
Let me ask anyone on our panel. I have heard, or maybe you, Liesl, as well, but I have heard that many times people leaving the prison or the jail infected may die in a hospital, but that death may not count on the prison side. That'll be a death counted somewhere else. Can somebody help me with that statistical issue?
I think that depends on the jurisdiction. There are some who, if somebody has been released to a hospital and they're no longer in custody, then you might be more likely to have that person's death not counted in the prison or jail's numbers. But a lot of people are sent to the hospital when they're still in custody. And so some jurisdictions would include those. So it just depends on where you are.
Great.
I agree with Liesl, because that's what we found out at the height of COVID. Numbers were readily available to us, but once the deaths and the number confirmed became positive, we saw the transition that people were being shipped out to the hospitals. And if they passed away at the hospital, the prison was not reporting it as a prison death, but as a hospital-based death in that jurisdiction, as Liesl said, which starts to skew the numbers of why everyone has different numbers.
That's really, really helpful, Deanna. Thank you so much. Let me turn to Homer and Ed for a minute and start to understand the environment and the climate of the institutions itself. Just give us, for those that may not be as familiar, I mean, it would seem that that there are probably some physical plant challenges, to say the least, in terms of these systems that are incompatible with optimal situation for trying to prevent COVID. Ed or Homer, do you want to go off mute and take that?
Sure. I mean, jails are not a place where you want to have a pandemic happen. They're small, confined places. Often jails in America have run out of space for treatment and for programming. The jails are too populated. This is why it was so important to do whatever we could to depopulate jails during the pandemic. It's what we call a congregate living environment. Many people are living together in very close quarters. They cannot control where they live. They don't have agency. And they may not have availability. It depends on the jurisdiction. It depends on the jail and the prison, the availability of masks and the enforcement of mask wearing. And the same is true with the availability of the vaccines. It really depends. And this is what Liesl was referring to. There aren't a lot of common standards that help govern jails and prisons throughout the United States. There's not a basic set of core standards that we all follow. So it depends upon who is in charge in your jurisdiction and what they consider important. But yes, being in a pandemic, being in a jail can be a scary place because there's so many things that you don't control.
Homer, you've done some investigation in this area, I know.
Yeah. So thank you, everybody. Thrilled to be here. I've been in about 40 or 50 facilities since the start of COVID, and most of that just looking at the adequacy of the COVID response using the CDC recommendations and other public health recommendations. And so I think that we all kind of generally understand the congregate nature of these places and how that promotes the spread of communicable disease. I think that there's a second thing that gets a lot of attention, which is there are a lot of people with risk factors for serious illness or death in these places. Both of those, I think we all kind of generally hear about and understand. There is, though, a third component that really flows straight from structural racism in our country, which is that the healthcare in these places was completely substandard before COVID ever hit. And so these are places that are rife with physical, sexual abuse, medical neglect, all the things, the structures that promote evidence-based care for everybody else in our communities, hospitals, community clinics, dialysis centers, our state departments of health, our CMS, other organizations, they've been essentially AWOL in these places. So you have local jail administrators and departments deciding what's good and what's bad healthcare. And the result is just high rates of jail and prison attributable death, lack of transparency about what happened or get sick, and extreme lowering of what we would think of as any kind of standard of care.
So, Homer, when you go in to do these visits that you've described, how are you getting access? Are you invited in? How does that work?
I'm almost never invited in. A judge determines that there's a problem. There may be a fight. A judge may appoint me as an independent expert, or I may go in as an expert on behalf of the people who are actually detained. In some cases, I have gone in to help the correctional system, but it's almost never a welcome inspection. There's often a lot of like performative preparation, cleaning, all this nonsense that happens with an inspection. But the most critical source of information for me is people who are detained, their experiences. I go to the COVID units where people are who have COVID, learn from them about what happened up to the point that they were hospitalized or they got COVID, go through those medical records, and then importantly, go through the medical records of people who have died. And what I see across the nation is, and this is where it's not just a data problem, it's a racism problem. It's that we think that the official narrative of what's happening in these places reflects the truth, and it doesn't. And so because we don't have DOHs, because we don't have independent monitoring of these places, the real experience of people who are behind bars, and many others on the panel have a much closer connection than that. But component of this pandemic is essentially lost.
I noticed a lot of the advocates were smiling when I asked the very naive question, how did you get access? Can some of our activists, advocates, can you help us to understand how it is that you can create the opportunities for people like Homer to come into these settings and do these assessments? How does it work?
They almost always have to be threatened with a lawsuit. Public policy as made through lawsuits are unfortunate but almost common way to get the correctional environment to bend to the will of public health needs. And so, Dr. Tuckson bringing this up now is absolutely critical. As I hear Dr. Venters talking about what we can't trust in terms of information coming out of carceral settings, there was a lot to do about COVID among the elderly in nursing homes when this first unfolded. I am almost certain that COVID among the elderly in incarceration was happening well before that. And that really speaks to the lack of regulation, monitoring, oversight that we have, at least in nursing homes, certainly was not in place in jails and prisons. And in particular, if you're thinking about people of frail health, elderly, serving these punitive, ridiculously long sentences from our war on drugs and other punitive measures, other racist measures, then we're really talking about an epicenter within an epidemic. And that is Black and brown people behind bars.
Wow, very strong. So I'm hoping that those out there in the audience who feel that there is a need in their community, in their state, their loved ones, and you feel like you feel powerless or hopeless to be able to find out what's going on. We've got people on this panel tonight who are examples of that. You don't have to give up, that you can do things through the legal system. And there's a lot of ways in which you can follow up after this show is over. Let me ask any of you who may have any observation about whether or not masks are commonly worn in these prisons and jails. I'm under the impression, and you'll help me, that oftentimes these institutions are in rural environments, smaller towns, and we know that rural America is unfortunately well overrepresented in the unvaccinated and the vaccine resistant. And we know that in many of these communities, there are a whole band of cultural people who feel alike, that why do I have to wear a mask? I can do what I want. And I have a feeling that maybe some of the correctional officers may be coming from that environment. Who can help us to understand what we think is going on in terms of the compliance with mask mandates inside?
I know I can share that. One of the things we have to know is prisons are in rural areas, the majority of prisons. The prison actually served as the employer of choice in those rural areas. It's kind of like a hospital or a Ford Motor Company. Typically, you get generations of family members working at those prisons. And you're right, Dr. Tuckson, they're from an era of, I don't have to wear masks, you're not going to take away my rights. And what we're finding from teachers who are actually teaching in that the guards are not wearing masks. They're just refusing to. And here's the deal. Administration is caught, because if you enforce the mask mandate or not ask people to work, you are actually running the chance of shortage on staff, which results in locking down a facility because you can't control the number of individuals inside the facility when there's a shortage of staff. So kind of administration is caught of how we keep this moving. One of the teachers did share with me that the population, when given the opportunity to get the vaccine, have taken advantage of the vaccine, but the guards have not. So we're caught in that dilemma of the actual staff that is getting paid by states working in a facility with a vulnerable population, and they're the ones going in and out to bring the COVID-19 back into the facilities. It's how do you balance that out, especially when you're kind of sitting in a burning building waiting on it to catch on fire?
Yeah, and if I can just jump in here as well, at Canny, so we are an independent oversight prison monitoring and oversight agency, and so even kind of jumping back to the former question, there are organizations, we're one of 3 in the entire United States that has the ability to monitor and oversee prisons, and in New York State we have that legislative authority in actuality to do that. And what we've found when we go in is that we do see many instances of not just with the masks, but when Dr. Venters was talking earlier about kind of this performative aspect, when we have conversations with folks who are incarcerated and we're talking about their experience, that's when we get to see whether they are wearing masks, whether they have access to healthcare, whether they're actually feeling like there is an increase in violence or abuse. We get to see the actual material conditions that they're under. And so even particularly in the case of masks, we have actually completed over 9 monitoring visits in the last year. And over 60% of the folks that we talked to, incarcerated people that we talked to, reported that the guards were not wearing masks. And so that's just to show you that we are seeing indeed, things where folks are not wearing masks, folks are not taking the proper precautions and putting people's lives at risk.
Dan, I think you were trying to get in earlier.
Yeah, I just wanted to share a depressing anecdote. So I live in Hawaii, and I saw that there's a lot of commenters too who are visiting us from Hawaii too. So I see what you're saying, and I'm so sorry about your struggles here. It is rough here. But I'm Maui recently. I mean, every jail on these islands has had their turn to take an outbreak, and so what happened was the mayor in Maui actually got together to purchase masks for everyone so that they could actually have them inside the jail there. Well, the COs refused to allow anyone to have them because of the little metal bars inside of the mask for fear that they could use them to harm themselves or harm other people. So, we're bumping into the way in which a correctional system is run in order to try and maintain order and make sure everyone is doing the right thing. And then also with like the very present health needs that everyone has as well. Another thing that I heard from another jail facility was that they wouldn't even allow people to use extra pieces of cloth or cloth masks because of the suicide risk. That one could use those as something to hang themselves with if they had that opportunity. So, it's really frustrating too, because, the mask debate is the mask conversation is like a good one to be having, but also it just shows that we are providing such inadequate levels of care across the board that really we're just begging for the smallest scrap. Allow people to wear a mask. When really there is just such that is one piece of such a broader picture, which is that the healthcare inside of these facilities is inadequate. The way these facilities are created is absolutely abysmal for stopping the spread of infectious diseases. And unfortunately, a lot of us are just fighting for the bare minimum of allowing people to have masks, and we're faced on all sides with people saying, no, absolutely not that too as well.
How do you all see the ability to attack some of these really real challenges? I mean, you're clearly making it that this is a complicated issue. And then, so that, again, as we've heard, if you try to mandate masks, then the folks won't come to work. Then you're in as bad a trouble as you were if you didn't have the mask. So it's a real kind of these challenges. It would seem then that the Bureau of Prisons would be in a place, or whatever federal dollars goes in, at least to the federal system. I don't know if any federal money is going into the state system, but at the federal level, why can't they hold institutions accountable for solving these problems as a condition of being funded? Why are we not seeing mass meetings and conferences where everybody comes together and a set of standards and best practices is formulated, implemented, and monitored?
There's
Shelley?
I would just say, in Florida, I mean, we have a lot of problems, but I mean, one of the things that I'm noting when I talk to the corrections officials and others, I mean, they were struggling before, and they're struggling to hire staff, to maintain staff, to keep staff. I mean, we're closing facilities and putting people tighter together because of staffing problems, and on top of that, this disease is a very confusing disease, and the messaging that's going out about it is very confusing, and the amount of misinformation that's out there is very confusing. And I really think we really have to work harder to simplify that message, both for staff and for the incarcerated population, in order to start to tackle some of these issues, because trying to have a conversation with so much complexity in the message has been very challenging. In working with both the correctional officers, the correctional staff, and also with the incarcerated population. I mean, I know, like we spoke earlier on this, that the masks when I went in they just weren't there at all. So I don't think like trying to get people to wear them would work at all here. So that's one of the things that I see, is that that the messaging is just so confounded at this point, and it really has got to get simpler, and trust has got to be rebuilt.
Let's talk about messaging for a minute and move a little bit towards vaccination for the inmates themselves, for the human beings that are housed in these facilities. What do we understand about their ability to make the decision to be vaccinated? And if they make that decision, do they have access to the actual service of being vaccinated? What do we know about that?
I think, again, it depends on the location and the institution. And in federal prisons, for example, I know they had an independent allocation of COVID-19 vaccine that started in December. And so folks were starting to get vaccinated in December of 2020. And as one of the other panelists mentioned, we do see higher vaccination rates among incarcerated people than we do among staff working in those facilities. And at this point, in the federal system, at least, everybody has been offered the vaccine at least once. But I know that's not true necessarily for all state systems and for all local jails that have different supply chains or different barriers to that. And there's also a difference in leadership at each institution. I think that there's a real role here for the wardens and for other leaders within the staffing component of the institutions to set the example. And we've heard anecdotally from institutions that have had high vaccination rates that a lot of that has been driven by high support from their executive staff and the warden sitting down and getting the jab in the arm where other staff can see them, and then staff getting vaccinated and people inside seeing that that staff are getting vaccinated and they can trust it. So there are a lot of issues of trust. There have been some surveys actually of incarcerated people about reasons why they haven't been vaccinated. And some of the top reasons that have come out have been trust in the safety of the vaccines, trust in whether they're getting the real vaccine. That some people think that they're being given a fake vaccine, they're being deprioritized in a way and not given the real thing. So I think there's a lot of work to do for, like you say, for communication to improve people's perceptions.
Other points of view?
I feel like we don't even need to go to the 10,000 foot view. Understanding that there is nothing about the way that the American carceral system has been developed that is pro-health. The public health infrastructure has always been completely separate from the carceral system. And as far as we're concerned, this is also, the onus is on the health system to acknowledge that people in corrections are their responsibility. I've had a health commissioner, a state health commissioner, tell me that the health department would never take on the responsibility of correctional health, and it shows. So we are both talking about the people who churn in and out of vulnerable communities because we've made investments in the name of public safety into carceral settings, into systems of monitoring and what I call toys for boys, kind of urban warfare. And we've divested from things that help keep communities healthy and safe. But the real issue here is that it is a siloed system. It is separate and apart from everything else. Partly that's money, right? Roach talked earlier about the money imperative. And I know Dan knows a lot about the whole piece of Medicaid, where we've built systems, workarounds because of restrictions on funding to take care of people who are incarcerated. But this has been decades in the making. And it's a little bit, I don't want to be discouraging, but running in with concerns about vaccines when people are getting sick and dying of preventable, treatable illnesses. And because of the control and surveillance, they don't get access to this. I mean, we really don't understand that the health care as it's rendered inside of the carceral setting looks nothing at all like what we're talking about in the community outside of carceral settings. It really is completely different.
So before I get to others on this, and I see Deanna, you're up next, I just want to let people know that Tracy's points were so impactful that at the end of the show, and listening to every word of the show, is the head of the American Public Health Association and the head of the National Association of City and County Health Officers. They are tuned to this show, and they will be making comments at the very end based on what they've heard. So Tracy, I think you've had a good receptivity to the points you were making. Deanna?
And I want to go and step back even further from what Tracy was talking about, focusing on the carceral system. Let's identify why the carceral system was even established at the abolishment of slavery, right? It still was a way to exploit the labor of individuals, i.e. Black people. And we built this massive system, which is why the majority of individuals in there are, for, like Tracy said, over-incarcerated, over-sentenced. But you have this historical legacy of slavery. You still have a 13th Amendment clause that says slavery is still legal when you're in a carceral state. Who is the biggest exploiter of that slavery? States. The State Department of Corrections. They use inmate labor for everything: landscaping, cooking, feeding, laundry. The state is the biggest utilizer of those individuals. So when we look at states looking for reasons or processes to protect the individuals that a judge has sentenced to the custody and care of the state, they're responsible for that care. And as Tracy says, that care looks nothing like it does in the community, which is why we have all these barriers. But you have to also go back. If I'm in a carceral state, I'm treated less than human, and now you want me to trust the medical that has not even been taking care of me for chronic illnesses around a vaccine. So what we didn't do, and what we always take privilege over, is when we rolled out this vaccine, that population was not a priority list to be educated. That population, you show up in a correctional facility saying, we have the cure to what's been killing people, and we want to utilize you. And every Black person in correctional facilities and the communities went back to Tuskegee experiment. You're getting ready to experiment on us, and we're not going to be subject to it. So people who are incarcerated, when you ask them why they did take the vaccine, it's because they finally got to talk to their mother. They finally got to talk to their family in a community who started telling them, please take it. Please take it, because they weren't having that interaction. But I want to go a step further. COVID is just national for us now. Correctional facilities have been dealing with healthcare scares throughout correctional facilities, climate change, and actually there's no plan. Correctional facilities and jails are the only congregate areas that are not mandated to have emergency management plans of how you're going to care for the people when a threat is imposed. We're looking at Texas ice storms, the Texas heat waves. Just during Ida, correctional facilities move people around, but yet again, the Humane Society had an evacuation plan for cats and dogs. This population is never prioritized. And even when CDC put out the guidelines of congregate living areas being in group 1A, prisons in some states were moved deliberately to the end of the line and not prioritized.
I saw Dan put his hand up, but I want to go to Ed. So Dan, you'll get in right quick. And then after that, Ed, you've had some successes in getting your populations vaccinated. And so we want to see what you, how that worked and what you did well. But Dan, I think you had your hand up a moment ago.
I can't say anything better than Deanna just did. So there's no point.
All right, Ed.
A lot of great points. I agree with the points Deanna made. And I want to underline what Tracy said. The future for corrections, it's really, we need to adopt public health models to respond to this. We have a huge opioid epidemic. We have a stimulant epidemic. Chronic incarceration itself is an epidemic that we can use public health strategies to address. And we have COVID. So we have solutions. We just have to use them. And I can say we can do this. I work in a rural jail, and we have over a 95% vaccine acceptance rate for our staff, our officers, and we have over an 87% vaccination rate for our incarcerated population. And that is simply, that's because we have run a program that's based on trauma-informed principles, on establishing trust, meeting people where they're at, and most importantly—
I'm sorry, Ed, could you just, as you develop that, you said trauma, you used a term that I want to make sure we all understand.
Yeah, and thank you, Dr. Tuxen. Trauma-informed, right? So in order to be incarcerated in most facilities in the country, people have a lot of trauma. You know, people who are in America's jails are very traumatized people. They have trauma from their childhood. They have trauma from their families. They have generational trauma. There's trauma in communities. And what we know from research of trauma is that this has a profound effect on future health, our physical health and our mental health. People who have a lot of trauma are, you know, more inclined to addiction, substance use. They're more inclined to violence later, more inclined to depression, anxiety, heart problems. So this is something that we understand much, much better than we did decades ago. But the treatment for trauma is not available in America's jails. People who are in jails have tremendous amounts of trauma historically and themselves, but this treatment's not available. And when we operate with a program that recognizes trauma, acknowledges that it happened, and we give education about it and treatment for it, a side effect of that is developing trust. And that was, I think, a big component of our success with our vaccination campaign, is offering a lot of education, a lot of materials to staff and to the people in the facility, and to really leaning into like with public health strategies. This is how we're going to solve the opioid stimulant epidemic. This is how we're going to solve COVID. And this is how we're going to address chronic incarceration. It's through public health strategies.
So tell me, I think it was either Deanna or Tracy, I can't remember which, that said, though, if mama calls in, or mama can reach somebody that and say, look, you should get vaccinated, that has a, so what are the triggers? Is that well, she wasn't being facetious, I think. But what are the kind of triggers of what can work? Who do we need to get to people to make the decision to decide they want vaccination? Whether or not they can get it done in the prison, that's a second issue. But you've got to start with the desire, I want to be vaccinated. What are the triggers?
Could I just problematize, I guess, the question too a little bit, like, because of what the current COVID situation is inside of these facilities, it makes it so that information and getting information to the folks who are incarcerated is so challenging, much more challenging than before. People are locked down here. Our Department of Health, they'll come in and they'll give the jab once a week. They'll say, Tuesday they're coming in to give the jab. No information about what it is, no talking through hesitancy, anything like that. And at the same time, people are not allowed to talk to their family. They're being totally cut off from anyone inside their family. So we have this incredible problem right now, which is there is no real information that gets inside of these facilities. I think Deanna, again, was completely on point. The people that I've heard from who got vaccinated on the outside after turning it down inside time and time again, the reason they give is because they finally had the chance to talk to their family. But right now, with COVID, with the lockdowns, with the measures that they're taking, these incredibly draconian measures that cared nothing about people's mental health inside these facilities, it makes it really challenging and impossible to actually have those messengers in there. And then add on top of that, our elected leaders also do think that people who are inside the facility are uniquely unreachable. This is what our lieutenant governor said here. The people who are in jail, they're not getting the vaccine because they're just the problem people. They're the ones that we can't ever reach for anything, which is 100% not true. And our lieutenant governor is a doctor. He should understand public health measures of being able to reach in, being able to use people who have been formerly incarcerated, being able to actually rely on people who have lived experience to be able to carry the message. And we just have not done that. So there's a lot of deprogramming that has to happen among our elected leaders in order for us to actually make these changes here. And I just want to point out that COVID is making some of the worst, most challenging communication aspects of just the way we've created our insane criminal legal system even worse now at this time.
By the way, I have heard, and you tell me whether it's true, is this unrealistic, but that trying to also, if you can reach the gang leaders inside of the prison, that might be a way to encourage people to get vaccinated. Is that off base, Deanna?
No, this is truly true. What we know inside correctional facilities is what they call security threat groups. They have leaders. And if you communicate with the leader, when you want to call a truce or you want the violence to stop, you don't just go in and talk to people. You pull the leaders of the various groups together to have the truce. If you want to educate a facility about a vaccine, you have to get the buy-in of a leader that everyone follows within that correctional facility. The problem, correctional facilities have identified that person as a threat because they are a leader. And they haven't figured out a way to utilize that person and treat them with human dignity and everyone else to communicate the importance of this. So they want to partner with other formerly incarcerated. But our problem is we can't be your credible messenger and then leave and you do something totally crazy as if a person has a reverse effect, side effect from the vaccine, and you don't give them health care because we know the health care is crazy. So we have to be careful of how we communicate. But if you want to get a message in any facility, all you have to identify is the leader of the security threat group and actually get them on board.
Well, I'm going to ask one. Oh, Felicia.
Yeah, so I was just going to jump in. I think that this has been a really rich discussion. And I think that even when you identify mom on the outside, when you identify the gang leader on the inside, you still have to recognize the actual experience of incarceration, the conditions of confinement. So we're talking about lack of ventilation. We're talking about mold. We're talking about vermin. We're talking about unclean water. We're talking about unhealthy food. We're talking about understaffed, inadequate, undersourced medical system. We're talking about creating a population of people who are really experiencing chronic and overall worse illnesses than that of the general population on a regular day. And then you overlay a pandemic of COVID and you recognize that it really intersects, because what we have seen in our work is that individuals are experiencing COVID-19 alongside all of the other issues that they experience on a daily basis. So they're experiencing trauma and the lack of healthcare and the poor conditions and violence and abuse and neglect, and it's aggravating the impact of COVID on folks who are actually inside. And so we're seeing this inability to social distance. We're seeing lack of masks. We are seeing literal increased violence by staff and widespread outbreaks, and really just a fear across the incarcerated population. And what we've seen, we've conducted a vaccine hesitancy survey in New York State as well. And we've seen that what folks have reported to us is that vaccine hesitancy is magnified by an overall lack of legitimacy in the prison system overall, and a lack of trust. And I think trust has come up time and time
there
again.
you go.
Really critical, because we have gotten reports where folks have said, I don't want to be a lab rat for this state. Or we've gotten reports where folks have said, well, when I am sick with like regularly, they give me, you know, Tylenol and they tell me to go back to my cell. I've seen people die from stomach cancer because they said, I'm not going to take care of you. Why is it that you think then I would turn around and allow you to give me a
Turn around. That's right.
So
Let me switch.
it's really important when we even talk about identifying, you know, people or, you know, strategies to increase vaccine uptake or to get folks taking it. We still have to understand, even when they do take it or even when it is offered, they're still operating in a very specific system that is not taking care of them because it does not see them as full human beings.
Let me switch over to Shelley for a minute.
That's right.
We're going to start transitioning from the inside to the outside in a minute. But Shelley, in this regard, we know that it's important for families to be able to visit their loved ones and that connection there. But how do you how fearful are you of having families now coming into these environments, and what's the risk to the families themselves?
Well, I think I want to segue in a couple of ways about this trauma-informed care and how our system is kind of creating this cycle with this. And that is, we had a young lady who is a child of an inmate who is also became a parent. She had a baby. And she had picked up a charge. She was on one of these ankle monitors, right? And 2 weeks afterwards, she's having postpartum. And she gets violated on a technical violation, right? So here we have a traumatized child who has a baby, a young mother, gets into the correctional facility, into the jail, right? She's in the jail. She can't do her court date on 3 different time periods because of COVID quarantines that occur. And so you end up in this cycle where she can't get out. We have a very small baby that's out there now that's having attachment issues, can't reconnect with the mother because the mother's in jail. So after she's been exposed to COVID now for like 3.5, 4 weeks, she gets released again back onto an electronic monitor based on the issue of the judge understanding that it was a postpartum kind of activity, effort, right? And then she comes home and exposes the brand new baby to what she's been exposed to in the jail. So when you talk about the public health and the corrections and criminal justice systems being separate, that is very much the situation in the decision making and how it works out. And, as we look to try to get children, I haven't seen in our state, they are doing some visitation, but the kids in our program, they haven't seen their parents in 16, 17 months. And, that is very hard on the kid. And it's very hard on those parents. But when you think about taking them in, we know that our children have higher rates of asthma. We know that the vaccination rates in these communities are lower than in other places. We know that many of them are being raised by grandparents and great-grandparents that are at higher risk with many underlying health conditions. So the thought of trying to reconnect them and weighing that connection is very difficult. And on top of it, they can't afford to get there. So we're transporting them, if we did it, on a bus, and which is a very enclosed space. So it is a very challenging situation, and it's further traumatizing the children and perpetuating the cycle, I fear, as to how do we get these kids reconnected with their parents where they can talk to them and feel their love and make it safe, and especially without masks and other things in the facilities.
Let me just add, Shelley, we're going to move on, but I want you just even though it would seem intuitively obvious, I want you to say it again in terms of why is it so important that these children see their parents inside these facilities, and how is it that it's not damaging to them to be in that environment?
Well, the children, we work with like over 6,000 children, and I would say these children, when they see their parent, they love their parent. They're kids. They don't understand the complexity of the criminal justice system or everything. And even if they do, they just want their parent to explain to them what's happening. And they still have the love between a parent and a child is unbreakable, regardless of what society thinks. And for these kids, they don't understand it. They don't understand why they can't see their parent. And they feel like it's a punishment on them. So they're serving the sentence that their parents serving, but they can't see their parent.
Okay.
It's
well,
hard.
Thank you. I'm going to bring into the conversation some new people. First of all of our special guests are still remaining with us. Shelley and Homer and Ed and Dan and Deanna, Tracy, Felicia, and Roach. But now we're going to add to our conversation two physicians who will not only, as we start to transition to discussing returning citizens and the process of returning, one of the things we also want to do in this segment is begin to get at some of the questions that family members have about making decisions about being vaccinated or wearing masks and so forth and so on. And so I'm glad to bring to the conversation Dr. Samira Brown. Dr. Brown has more than 10 years of primary care pediatric experience, co-founder of Little Lives PPE, and currently practices at the Piedmont Healthcare in Atlanta. Also, Dr. Jihan El Bayoumi, or we call her Gigi. Gigi is a professor of medicine at GW School of Medicine, and she has a very active clinical practice. She's the founder of the Rodham Institute, and that's all about community knowing best its own health needs and priorities. She works in partnerships with numerous community-based organizations, with local government in DC to meet community-based needs. And she's also a co-founder of the Black Coalition Against COVID. And so let me start this transition by asking Homer again. You made some comments early on about the need to integrate in a more seamless way. I think you were saying what happens in terms of the healthcare delivery system inside of the prisons and jails with what happens outside. Can you expand on that just a little bit more?
Sure. I think that if I said to more seamlessly integrate, I misspoke. We need some integration because we have essentially none. We built this system, as Deanna and Tracy and others have mentioned so clearly and eloquently, to be separate, to actually resist transparency. So we have jailers deciding what's good healthcare. We have people who are not healthcare professionals leading the decisions about what's the scope of services, how quality is assessed, and importantly, when people die, we don't have the answer to a very simple question, which is, did conditions behind bars contribute to the death? Was this a jail attributable death or prison attributable death? And that's because the DOHs of states, and for a long time the CDC and all of our other evidence-based structures aren't involved in these areas. And so for me, doing this work now, this is the central question, and I think talk is pretty cheap. I'm tired of hearing from commissioners of health from states or from colleagues at the federal level that they care about this because of COVID. If your job is to care about the public health, then you need to get yourself inside jails and prisons, and you need to measure the quality of care, and you also need to measure this other thing we haven't even talked about explicitly, which is the health risks of incarceration. One of the most common health problems in incarceration is injury. But if you went to any state DOH website and looked at injury prevention, if you went to the CDC website or other big public health structures that talk about injury prevention, you wouldn't see them measuring and talking about injuries that happen behind bars. And so for me, when I say talk is cheap, I mean, what are you going to do? Are you really going to own up to the real mission of protecting health that includes people behind bars? Or are you just going to talk a little bit about COVID and then move on?
Roach, you started to talk earlier, and I know you've been concerned. What is your observation about the adequacy of the transition process from coming, if you're inside and now you're on your way out? Is there a safety net that catches you and manages you and facilitates you? Do you ever see that, Roach?
Well, in very few instances, the COVID-19 has impacted prisons in a way that has never been impacted before. You don't, the guy I mentioned at the top of the show who did the 50 years in prison, he was called into the office and he had never expected to be released. And they told him he was going home in 48 hours and his bowels broke. He went into shock and they put him in the infirmary and they released him. And there was no preparation for reentry support, mental, social, psychological, financial, whatever. There was none. They dumped him on the street. And there's, depending on what state you're in or what system you're in, you may or may not get a modicum of support upon your release. But this is a crisis. I just mentioned them two guys did the 40 and the 50 years. There's thousands of men and women being released or have been released due to the COVID-19 on compassion release. And they don't have a place to stay. They don't have an income. They have no jobs. Socially, they are very, I won't say immature, they're like almost infantile when they don't know how to access the phones. They don't know how to access the bathroom. Besides taking care of their basic needs, the mentally. Let me back up and say this. Somebody said earlier, Doc, about prisons and why the guys won't take the vaccination. One of the reasons there's no trust in the medical department. The medical departments in all institutions are substandard, to say the least. You can break your leg and they'll tell you to go here, take these 2 aspirins and call me back. I'll come to see you in the morning. They know that regardless of what's wrong with you, you don't get the adequate treatment. And somebody also said that the professional expertise and training and education is lacking in a whole lot of these facilities. And secondly, they've transferred or contracted out medical services to private medical agencies that's doing it, and they're concerned about the bottom line, not the life of the patient. And Chief Justice Earl Warren said, "You are sent to prison as punishment, not to be punished," and that has been lost in the transition. And we're being treated like dogs and animals inside. And when someone's life is at stake, hey, it doesn't matter what color you are, how tall you are, whatever. Man, if you're sick, you're sick. And they don't, and every week on TV, you see somebody is being released after 20, 30, 40 years in prison due to a lie or a mistake or withholding of evidence. And you lose all sense of trust. Then you go in a prison environment and every day you are totally wrong. You're never right. No matter what your issue is, what your complaint is, or what your concern is, in prison, you're wrong. And you don't have any trust built up inside. So when they come in with a vaccination, man, the hell with that. They ain't going to take it for what? But one of the people who going to help them is the women, the mothers, somebody they trust. If the mama or their wife that they trust and say, hey, we took it. You had to utilize every tool in our toolkit. We're talking about lives, people.
Good.
Human
Thank you,
beings.
Roach. That's beautiful. And so moving that down that road, Dan, you've created some important work, with Medicaid. And I know that, for example, when people come out, one of the things that we've been doing with our Black Coalition Against COVID in DC, working with Roach and others, and with the people, we have some really good people that are running our returning citizens program in Washington, D.C. And in fact, he's going to be on at the end of the show as well, to what he heard. But we really have tried to figure out how do you capture getting folk eligible for Medicaid when they come out so we can refer them on. What are you learning, Dan?
Yeah. So, one big step back. Why do we even have this problem to begin with? And this is because 1965, when the Social Security Act created Medicaid, they said, all right, you can remain eligible for Medicaid, but you can't get any Medicaid services if you're an inmate of a public institution. So you might be someone who's receiving Medicaid in the community. You might have a mental health condition that in receiving treatment for that, or you're getting substance abuse treatment, anything. You get arrested, taken to jail. You're in jail for 3 days. That 3 days knocks you off of the Medicaid roll. You actually don't have access to Medicaid anymore. That allows the jail healthcare system to create its own world and a different environment outside of the broader healthcare system on the outside, and allows the healthcare system outside and inside to grow and diverge in two completely different directions, and the two never communicate with each other. So what we try and do at Coaches, the nonprofit that I work at, is we try and change policies to make it either easier so that people can get access to Medicaid, so that when they're released, then they can actually avail themselves of the entire bevy of services that are available for people who are in the community. I'm sorry. Of course, as soon as I'm on air, the dogs and chickens start going crazy. And then, so we try and make it the most easy way of accessing Medicaid for when people are released. The problem is that you can try and get someone enrolled in Medicaid so that the day that they hit the ground running on the outside, they then have to face challenges of they don't have their pharmacy benefit turned on yet. So how do they get the medication that works for them? So all that to say is that we have some major structural barriers that are built into the way that we provide healthcare services to folks who need it, who income qualify. And so what a lot of jurisdictions are doing is say, how do we, in the face of these structural inadequacies, how do we get people enrolled at the very beginning in order to allow them to take advantage of what's out there? And, a big problem of this structural inadequacy that we have, or structural problem that we have here, is that it made it so that we really can't build these systems so that people can reach in and be reimbursed for the work that they're doing, because that has to come from a totally different pot if they're receiving Medicaid funds on the outside. And if they are the types of organizations that are doing the reach in and doing the really great job of trying to engage people before they're released, they're funded by contracts or grants that go from year to year. They're constantly fighting to be able to have long-term sustainability. And you know what happens is when they apply for the same grant year 2 or year 3, they say, well, why didn't you make this financially feasible on the long term? And it's because of the structural barrier of the Medicaid inmate exclusion.
Ed, you in your work, you sort of start out, as you've said, as I've read about your work, from preparing people to leave the institution the day they come in. What does that sort of mean, and what are you trying to establish that that will really help facilitate a smoother transition from inside to outside?
Yes. So Dan pointed out a big structural problem related to Medicaid. One of the first things that we do when someone is incarcerated in our facility is right from the bat, we conduct a variety of assessments to find out where that person's at and what they need. One of the things that we ask for is, do you have health insurance? And we get all the paperwork filed that all of the preparation is done in advance. So that the time that they're released, we're ready to go, we're ready to activate. So there's a lot of preparation for reentry planning, case planning, and then there's as many treatment interventions as we can cram in, as we can offer to people while they're in our custody. When someone comes in to our custody, if we are doing nothing to support them and to help them, then we're doing nothing really for public safety. That person is going to be released back into the community. In Massachusetts, an average person, if you picked randomly in a jail, will have had 5 prior convictions. So chronic incarceration is a real big problem, and it needs to be interrupted in order to support public safety. And so that requires a lot of planning.
And before, I'm going to go back to our panel to just finish doing this a little bit more work on how do we create a more helpful system along the line of what Ed has said. But I want to just give an early warning. If you in the audience have questions about the vaccine, about masks, any of the science, this is the time to put them in the chat, because before a few minutes more, we're going to use our medical experts to answer those questions. And Ellis, our producer, will be standing by to present those questions. In addition, I know that all of our panelists are familiar with the kinds of questions that your constituency are asking about, the safety, whatever it may be. So I want our panelists to get prepared to ask the questions that you think are most on the minds of the audience as they try to make decisions about vaccines, about masks, and so forth. But I'm giving you early warning. But before we go there, let me just ask again of Deanna and Tracy and Shelley, Felicia, what are you seeing from your experience that can help us to try to overcome, or what should we be aware of in making the successful transition from inside to outside?
I'm just going to say, reentry is a term that we use to talk about people coming from carceral settings to the community, but it's no different and should be no different than what we talk about when we say hospital discharge, right? That you have to have a place to go home to, that you have been engaged before you leave the acute setting, that there is going to be follow-up. This is what is standard and in many cases governed and insisted upon by regulation, law, and policy, that when people leave institutions of care, that they have a transition plan. And yet we have nothing for people who come from carceral settings, who come home, who in many cases have more interaction with the criminal legal system than they do our healthcare system. And I want to make it very clear. There are people in this country who would be perfectly happy for Black and brown people to get their care while incarcerated. Incarceration is a chronic health condition. The trauma of incarceration is going to add to or definitely get in the way of anybody getting healthy. And there's one thing, and I'll shut up, that I want to point out again to bring home the point that if you even look at resources, health, in part because of Medicaid, has so much more resources. This is not to say that incarceration wasn't built to provide care. Hence, it doesn't have the systems to do it. Health does. And unless somebody hits lottery while they're inside, they will qualify for Medicaid coming out. In New York, we have a law that mandates the oversight of the correction system by the State Department of Health on 2 health conditions, HIV and Hep C. We worked with the Correctional Association to get it passed in 2009, and the health department hated it, but the corrections didn't because they actually wanted the guidance. 10 years, 11 years later, we have better viral suppression of HIV inside than we do in some communities in New York City. And Hep C has been cured in our state prisons to the envy of other prison systems around the country. The health department, I don't care, needs to be dragged kicking and screaming into care for people. Incarceration should not be left on its own to provide health care.
Can I just build on that? I mean, one of the things that occurs to me is when we have our political system and our state legislatures and the counties and everything, you have committees set up. So you have a corrections or criminal justice committee, you have a health committee, right? But we need to be getting our Department of Children and Families, our Department of our health committee, the people who oversee them, and our people who oversee our criminal justice city to meet together sometime to deal with some of these silos. I mean, that's one of the challenges that I see, is that not only are we having problem with chronic incarceration being a public health issue for the individuals that are incarcerated, but it's affecting their families generation after generation because the kids are being impacted. Not that the kids end up, but it is a traumatic experience to have your parent incarcerated. We recently had a visit from the current Miss USA, and her father was incarcerated. And just to hear her talk about how it impacted her family and her life and what she had to overcome, you just realize how we perpetuate that when we don't work together and really integrate the systems across so that we can deal with these issues. So
perfect. Deanna, is that you still, or did you want?
Yeah, I was just going to build off.
Deanna, one second. By the way, if Jay Butler can hear us, Jay, we want you to come back into the studio when we go to the Q&A section, because you know as much about the answer to all of these questions as anybody in the world. Go ahead, Deanna. I'm sorry.
No, I was just going to build off of what Tracy said about identifying it as leaving a system of care, because technically, when a person is incarcerated or sentenced by a judge, everyone forgets when he hits the gavel, he says, I sentence you to the custody and care of the State Department of Corrections, meaning your care is supposed to be provided in that system. And if we stop siloing and saying re-entry and actually look at it as discharge planning and making sure those elements are in place, you will have a better outcome. But then again, connecting on the outside of how the systems actually prepare to and actually welcome people back. But secondly, I'm happy, Dr. Tuckson, you said the head of the City and County Association is on here, because counties and cities, if they look at their correctional budget, their city and county budget, corrections is typically the highest. And when they dig down into their correction budget, they're going to see the medical contract that they give out is the highest. And the population in your local jail and your county jail is a revolving door, that if you utilize access to healthcare, Medicaid, and things that they are eligible for while they're on the outside, because the Medicaid will not terminate until they've been incarcerated 30 days. So if you have a revolving population, that medical care that you're giving them inside that facility can actually be billed to Medicaid. And when we did that in one county, that correctional health care provider had to reimburse that county $2.5 million in 1 year.
Wow. All right. And then lastly, as we get ready to turn to the Q&A, I want to make sure, does any of you have any insight as to whether or not private doctors in the community, or there are clinics in the community that are accepting people when they come out? Or are we finding that people don't have anywhere to go to get their care simply because, well, you were an inmate, I don't want to, have anything to do with you? Do we have any insight into whether that is a problem or not?
I have to tell my FQHC story. I was meeting with someone who represented the national FQHCs, who was talking about this, it was about reentry and how to work with people to get them connected to care. And this national representative said, working with the corrections population is very difficult. They don't keep appointments. They are disruptive in the waiting rooms, and they don't come back for follow-up visits. And again, this goes to the issue that how healthcare is rendered on the inside, and the fact that we have consigned people to get their healthcare through the carceral system, since we keep churning them in and out, is why individuals don't know health literacy, how to navigate our very complex health system. And so we have a healthcare system, we have a carceral system where the default pronoun is male, and that men do not get health literacy. Men do not have to go to the doctor in the way that women do. And women, let's not talk about their care inside of the carceral setting, but men in particular, sad as it is, in often cases learn their health literacy or their health skills through incarceration. So unless we get these community organizations to come inside and work with the community that is theirs, that they get federal dollars to take care of, we are going to continue to have this disconnect.
All right. Let me turn to, as we wrap up this section and go to the Q&As, I want to, Shelley, make sure that I'm clear. What do you see as best practices, or what have you learned about the optimal way to bring people back into the community in terms of family reunification? And how can we help make the families making good decisions to protect themselves against COVID as a team together?
Well, with the coming back, part of it is the education and the messaging that I talked about earlier, and the trust. And I think that, what we've seen is that coming back has not been very smooth. And, in some of the families, they have a better sense of it, and they are separating the children and those who are at risk for the initial 2 weeks. But a lot of them, they're living in very difficult situations with, many people in the household, and the person gets, released, and they're bringing them back into the household with that exposure. This is particularly problematic, we're finding, with those who are in the jail and the revolving door situations. And so we've seen families where, we've been trying to work with them and message to them, if your loved one is in a jail situation and going through technical violations and stuff, you need to be putting in some protocols about the quarantine when you come back in. But, they're so excited to see their family member, because many of them haven't seen them in so long, that, the optimal way is to try to build that bridge and to talk about the health and safety as a very pivotal point. And the health and safety of the kids and the elderly individuals that are living in those households to them when they get out, and helping them to understand the risks that they bring back to their households.
Shelley, this is such an important point. And I think we really have to understand that so often the caregiver for the children of those who are incarcerated is an older person, a person with multiple chronic illnesses, people who are themselves at risk. Dr. Gigi, we have heard earlier that that many people in this population, like across communities of color, hear the Tuskegee word and immediately start running in the opposite direction. You've heard that enough. What do you say, and what do you want to say tonight to anybody in the audience who is thinking about Tuskegee as a reason not to get vaccinated?
Well, thank you, Dr. Tuckson. What I would say to people in the audience is, please, and I hope Mr. Ellis will put the link in the chat, take a look at the ad that was done in partnership with Black Coalition Against COVID and the Ad Council, it is actually featuring 6 of the descendants of those men who were part of the Tuskegee experiment. These descendants remind us of who those men were, how they were not treated with syphilis. They helped to educate us that syphilis was not injected into these men. Rather, they were prevented from getting treatment, which was penicillin, and other people were getting treated, but they the people that were doing the research wanted to see what syphilis untreated would look like. And that's really where the disgusting and criminal aspect of this study was. But the descendants of Tuskegee, which I had the honor and privilege of actually seeing speak and learning about their family members as fathers, uncles, cousins, brothers, was that these, they don't want their own name to be used in vain. They support vaccinations. It allowed us to hear from them their perspective about clinical trials. And because they did not want their family members to have been in this awful experiment, in vain and not have lessons learned, a lot of what has happened as a result of this criminal experiment is that there have been safety protocols placed. There are what are called institutionalized review boards. So you can learn about all this. I would suggest that you look at that 3-minute video, but suffice it to say, the descendants of the Tuskegee Institute have all gotten vaccinated. They do not want their family members' names to be used to justify not getting the vaccine. I think there are lots of myths about the Tuskegee. I mean, it's like anything which causes a visceral reaction. We're upset, we're angry, but sometimes we don't know the specifics of what the Tuskegee experiment was. It was not injecting syphilis into those men. It was preventing those men from getting treatment. So I would really encourage, and I hope, Mr. Ellis, you put the link in the chat. These are important things, because when people mention Tuskegee, or when they mention anything about a reason that they want to decline the vaccine, what I do is I say, tell me more. Why do you feel this way? I'm not going to launch into a lecture because it's not going to be helpful, right? These are emotional issues that come from generations and generations and generations of trauma that is embedded in the DNA. And it actually is kind of insulting when you just start to launch into something without really understanding where people are coming from, and it's not productive.
I really think this is so important, and you've really got me when you really stop and think about what Dr. Gigi is saying, is that here was a situation where Black men were denied access to the treatment that would have saved their lives. Now, many people in our community are using Tuskegee as a reason to deny ourselves the treatment that would save our lives. It just makes it makes no sense. Shelley, you have been thinking about the issues of children and returning. If you could ask Dr. Brown, our pediatrician, one question that comes up the most as you try to talk to family members about getting vaccinated or taking appropriate precautions, what's the question or the issue that you get hit the most that we want to direct to Dr. Brown?
Well, I have 2. One is that I get from the incarcerated parents, and that is, how is this going to impact my ability to have children? There's a real sense about that. And then from the family members, it's like, the vaccine doesn't work, so why should I take it? You can still have COVID and with the vaccine, there's no need to take it.
So those are, 2 really common questions that we get in the pediatric office, as well. And they're great questions. So when we first talk about in terms of if you're trying to get pregnant or if you're trying to have children in the future, male or female, it absolutely is safe to get the vaccine. There is no evidence that the vaccine has any effect on fertility. And so it is not only safe for those who are planning, to have children in the future, but also those who are pregnant. And certainly we know that those who are pregnant and close postpartum are at increased risk for suffer more complications of COVID. So it's really important, especially that high-risk population is fully vaccinated. And then the second part of your question, Shelley, if you'll say that part of the question again.
There's a general belief that, because of the messaging that, getting the vaccination doesn't, why should I get it? You can still get COVID and have COVID even if you're vaccinated. So, that's what I've heard. So if I'm going to get it anyway, there's no need to get the vaccination.
And this too is just very common that we hear really all over. And so when we're talking about getting vaccinated, you want to remember that while no vaccine is 100%, there is a very big difference in terms of being vaccinated versus unvaccinated. And there is a small percentage of those who are vaccinated who can get the illness, but then they're going to have a much milder course of illness. And there is a 20-fold decrease in your chance of being hospitalized or losing your life to COVID if you're vaccinated. So there is definitely a big difference. And you also help to protect your loved ones around you. So certainly children under 12 are not able to get vaccinated yet, and they definitely need protection. Or if you have someone in your home who may be immunocompromised or at higher risk, certainly you getting vaccinated not only protects yourself, but it also protects your loved ones.
Great.
So
Did you
can I
want to
get-
augment?
Yes, I want to give an analogy because I sometimes think that the public health messaging hasn't been very strong. So this is my analogy. Feel free to use it. The COVID situation is like a hurricane, right? The story is evolving, and we should, just like the news reporters say, stay tuned for updates. This is a changing story, so it's true in the same way. When there's a hurricane, people say run for cover. If you can get into a big shelter, where they house people and there is food and beds and so forth, that's safe. Now, being in that safe shelter, does it guarantee that the hurricane is not going to hit there? No, but the chances of dying from the hurricane go down substantially. So it is true with the vaccine. The vaccine is not 100% guarantee, but it is as though you're in that shelter. The chances of dying and getting, not just dying, because death is only one outcome. Sometimes we think about death and life, but actually there's something else, which is living with the long hauler COVID symptoms. Yesterday, Mr. Ellis knows we had a show with Pastor Webb, who survived COVID. And she has a book called Dark Shadows, My Journey with COVID. And she was talking about how it's affected her circulatory system. She had high blood pressure. Her doctor had to add more blood pressure medications because her, it's not well controlled. There are all kinds of other consequences, not to mention the mental health consequences of having COVID. Can you imagine not being able to breathe? And then it's like you're having this awful dream of being underwater and not being able to, you just think about that as you're about to fall asleep in your bed, and that's the image that comes up.
That ought to really motivate everybody to say, look, that's the last thing that you want. And
It's
all the
awful.
all the reports we hear every day of people literally on death's door begging to get the vaccine, which of course we all know, and I make sure that everybody in the audience knows, the vaccine cannot help you after you have already gotten sick. So you've got to do it on the front end. Deanna, what question do you hear often that you want to ask our experts? And I think Dr. Butler is also back. So we have the team of Dr. Brown, Dr. Gigi, and Dr. Butler.
So I think one of the questions that we always come up with is how, as from a medical standpoint, how do we start to convince jail administrators and correctional administrators on what we can do to actually prepare? I think proactive activities. I also think one of the things that I've been thinking about, being a former employee of a Department of Corrections, is understanding that I'm working with a vulnerable population, and this population is never considered vulnerable. But if I take a job at a nursing home, there are certain things I know that I have to keep that job, I have to do because of the population I'm working with. that has not been translated to the correctional community as well, which is, as Tracy talked about, when we talk about the number of elderly people who are incarcerated, we are walking into buildings containing vulnerable population who have very limited alternatives to whatever happens, right? At the mercy of administrators. How do we as advocates start to have that conversation with correctional administrators from a public health perspective to move this needle?
You know, I think that's a really, really great question. I'm going to cheat on you, Deanna. I'm going to hold that question for a minute, and I'm going to remind the panelists, those that are not the doctors, that before, when we get to the end of this section, which is about 10 minutes, I'm going to ask each and every one of you in a lightning round to tell us what is your guidance and advice for how we can do just that very thing. Deanna, you are my favorite person. You step right in the trap. I love it, and I'm coming back at you. But so hold on. By the way, it gives you a chance to start thinking of the answer. Felicia, what's the medical question that you have for our panel?
Yeah, so what we've heard from folks who are inside are questions around getting the vaccine when they have longstanding chronic illnesses, and what would be the interaction of the vaccine with some of those illnesses.
Jay, let me start with you on that, and then we'll go to others.
Yeah, great. So the early studies of the vaccine really were designed recognizing that people with chronic underlying conditions such as heart disease, lung disease, liver disease are at increased risk of severe COVID, increased risk of death from COVID. So there was a lot of focus on being able to determine whether or not the vaccine would be safe and effective in those groups. To summarize a lot of data, the answer is yes, they are safe, they are effective. The one exception is people with immunocompromising conditions. And these are people who may have HIV that's not under control or are on very powerful drugs to treat cancer or inflammatory states. And that's one of the reasons why is the data has continued to be reviewed. The CDC has recently recommended that those people should actually get a third dose of the vaccine as well. The evidence is there, again, that it's safe, but it also increases the effectiveness by increasing the antibody level among those people who don't respond very well. So to sort of cut to the chase of the question of how does the vaccine interact with the chronic illnesses, it actually reduces the chance of dying of COVID because of the increased risk that's created by those underlying illnesses.
That is so important that we all understand. If you are someone with pre-existing conditions, diabetes, obesity, heart disease, kidney disease, yours should be first in line to get vaccinated. It's for you very, very, very much. Let's go to the next question. And I think, Dan, you're next. Did you have a question to ask the medical panel?
Yeah, I'd be happy to. So hear a lot of concerns from people. This vaccine was rushed. They didn't test everything. I was wondering if anybody could comment on that. What happened with the testing of this?
Sure. So first of all, the technology of the vaccine is probably about 10 years old. And the positive part of this story has not been told. Look what happens when scientists, researchers, the public health community, the health community get together from all over the world, and we're all dealing with a crisis that affects all of humanity, and we put our heads together and we test this vaccine. What the outcome is so amazing that a vaccine whose technology has been around for a while can be developed. It's not record time. It shows you, first of all, we lucked out in one way. As horrible as this COVID virus has been, it's actually a really simple virus. If we compare it with the HIV virus, if we had to deal with HIV in this kind of how contagious it is as COVID, we'd be in big trouble, because 40 years later, we still don't have a vaccine against HIV. So in a way, the simplicity of this virus made it easier and quicker to be able to develop a vaccine. The other thing that I want to just say is that there are billions now of people who've gotten the vaccine. And so when we're trying, I'll do my best to explain this concept. And if I'm not successful, maybe my colleagues can jump in. When you are looking at the safety of any medication or vaccine or device, it's dependent on how many people get that, medication, let's say, or vaccine. If you're only going to have 10 people get it in a year, it's going to take probably centuries to figure out if it's going to be safe or not, right? Because you have to wait and get all this data and accumulate and see if it's causing any negative effects. But when there are millions and now billions of people, the ability to establish whether it is a safe treatment, vaccine, medication is much, it's faster to try to determine that because there's so many more people that are getting this. So if there was a problem, it would surely turn up very, very quickly. And so the good part of this story that's not really been told is it is safe. We're lucky. We may not be so lucky as this virus mutates.
You didn't need any help. You got it just right. Just right. We're now going to do some lightning round questions. So everyone is going to be short answers. We want to squeeze as many as we can in now. And I think the next person in line is Tracy.
Okay. I am confused by all of the conflicting information as a parent with school-age children. What's the best resource that will inform me about what I should know about sending my child to school?
Okay, Samara.
So certainly the CDC has great guidance in terms of children going back to school, and also the American Academy of Pediatrics. If you go to healthychildren.org, that is a great website that has many resources for kids going back to school.
So what is that again?
Healthychildren.org, which is the website of the American Academy of Pediatrics.
Thank you very much. Perfect. Shelley.
Lightning round scared me. So you talk about this vaccine as a technology. I mean, I'm pretty sure there's a microchip in it.
There's not.
Well, I'll say this. There's a chip right here in this device, and it actually tracks everything you do, everything you say, and it's very effective. You don't need to get an injection.
Ellis, from the chat line, give us a quick few that the audience is asking about.
Yeah, so there was a couple of good ones I wrote down. One was, are there any states or facilities that are models for best practices in care and discharge for inmates?
Best practices for discharge and care for inmates. Where anybody doing it great, or any particular part of something that's doing great. We know that one place we know of, and that is where Brother Hayes is. He's doing a good job. Anybody else have any examples?
See, during COVID or general? Oh, go ahead.
Yeah. I mean, in theory, Cook County has a infrastructure to help people transition. They have the healthcare a little bit better integrated, but none of them are stellar.
All right.
Right.
Dan.
I was going to follow up on that. Louisiana has done a really surprisingly good job as people are leaving prison. The problem is that there's jails as well, and jails are a lot more challenging to be able to try and work on that transition out of a correctional.
Why is that?
Because the time you're there is so short. The average length of stay in a jail is 25.1 days. It's enough to absolutely ruin your life, but not enough time to be able to help you kind of start integrating into maybe some of the supports you might have needed in the community. And so what happens is they'll release people at 2 a.m. You don't know. They could be released from the courthouse. They could be released. Some sheriffs have the capacity to release, not every jurisdiction. So it's completely different. At the prison level, it's run by the state. You know when you're going to be gone on this day. You're going to be parole hearing this day. Completely different world.
Ellis, last question from the audience. Do you have one more?
Yeah, this is kind of more of in line with some of the conspiracy theories and they've been expressed, and that's are people dying from the vaccine?
Oh, Jay, please, you are in charge of this whole area and monitoring for the CDC. Please, you are the one guy that can definitely give us the answer.
I will give you a very straightforward answer. Almost never. there is at least one instance where myocarditis, which is a very rare complication of the mRNA vaccine, has developed in someone who subsequently died. In most cases of myocarditis, though, it's very, very mild. So, if we say, I think we almost never say never or always, but it's so extraordinarily rare. Just play the odds, get the vaccine. It is so much safer than the COVID-19 infection. Also, when we're talking about even mild myocarditis, the risk of myocarditis from infection by COVID-19 is much greater than the risk from the vaccine.
Well, it's great. Well, listen, here's what we're going to do, folks. We're nearing the end of the show, and we did say that we've got some people who are in positions of authority who have been listening carefully and lessons learned. What I want to do is I'm going to go around the horn and ask each of our advocacy experts to very, very succinctly just say the one thing that you think will make the biggest difference in enhancing the safety and the health of incarcerated persons, those who are now living in our community, and their family members. And Ellis, as each one of them, after they've made their comment, we can take them out of the studio and bring in one of our guests for the last 15 minutes. I'm going to start with Homer, and Homer. No, I'm sorry. I'm going to start with Deanna, because she's the one that kind of got us down this road. So Deanna should get the first shot. Deanna, I think you asked a provocative question. Would you answer your own question, please?
So no, my question was, how do we start having this conversation with corrections to partner with public health? And what we saw previously in years before, that in states, substance abuse, the Department of Substance Abuse and Department of Mental Health were separate. But when they started to see a correlation, those departments and states started to partner and work together, and in some cases, literally merged. How do we, corrections is not an entity silo by itself. We have to start including a public health perspective. So I think most states have criminal justice coordinating councils, and we have to invite public health to those tables when we start to strategize.
Thank you. Good job. Felicia, lightning round, 1 minute, go.
I think that one of the most important things is to look at incarceration as a public health issue. And I think until we start to look at it as a public health issue, we can't address the actual things that are going on. And then the second thing I'd say is to decouple healthcare from carceral facilities and carceral systems, because they will not do it well.
Thank you so much, Felicia. Homer, 1 minute, lightning round.
Yes, my question challenge is, will state departments of health and the CDC finally take on the responsibility, or be forced to take on the responsibility of tracking, promoting the health of people in carceral settings? And this includes tracking the health risks of incarceration. And if they don't expand past COVID to include all the other aspects of health and health care that happen behind bars, then I think we will know a lot about the true motives behind the discussions we're having right now.
Thank you so much, Homer. Really appreciate it. Lightning round. Next is Tracy.
You're going to be able to kind of throw me out easily, because Felicia and Dr. Venters went right to my issue, which is we need to have health run health, regardless of the environment. So correctional health and community health are inextricable.
Thank you very much, Tracy. Shelley.
Well, my thing would be back to, I mean, it's a confusing disease. It needs a simple message, sort of like see something, say something. Dr. Gigi, I really appreciate your hurricane example, because I think that in order to explain this to individuals, we've just got to have more materials that are simpler to digest.
Perfect. Thank you so much. And then Dan.
Yeah, just to echo what everyone else has said, really start identifying and hitting over and over again that jails are just a transition of care. It's a place where people receive care, and it should be offered at the same level of quality, transparency, that we offer it in the community. So that's my big takeaway. A little bonus takeaway is run for sheriff and run for prosecutor. Those are elected positions, they're local positions, and they have an incredible amount of say over how the healthcare is done, how diversion is done inside of these settings. And you all have the power to be able to really do some big changes. And it doesn't take a lot of votes to be able to do it, because people don't pay attention to those elections very much, and you can do it.
Wow, Dan, I have to say, wait a minute, even though we're flying by, that is an incredibly important point, quite frankly, and I'm embarrassed that I had not ever thought of it. Thank you for that. We got to add that to the agenda, and I think that's something I'm going to put on my agenda as well. In terms of the health issues, if there was one thing you could have for healthy families, Dr. Brown, for healthy children, what is the one piece of advice that you are pleading with every parent who is watching this show right now?
Yes, please know that kids can get COVID. They can definitely transmit COVID, and they need to be protected. So if they're 12 and up, the best way to do that is to get them vaccinated. It is absolutely safe for children to get the Pfizer vaccine from 12 and up. And also, all your loved ones you want to vaccinate around your children. So please don't wait. Go today.
Thank you so much. Dr. Gigi.
Get the vaccine. Getting the vaccine is an act of love. It is life affirming. It is, I think people are so scared now. Everything is so fear-based. But I don't know about you, but I've got a lot more living to do. And I know that the people that I love and the patients that I care about, I want to see people live a quality of life that they can dance and see their family and work and do all the things that they love. Getting the vaccine is life affirming. It's protecting yourself and your loved ones.
Thank you so much, Dr. Gigi. And I would make my add to it, please wear your masks. Even if you're vaccinated, you should wear your mask when you're indoors with people you don't know, just to make sure that you are well protected and that they are protected. And also remember, there is nothing political about a piece of cloth. Just please, let's just get past all this silliness about your individual rights and so forth and so on. If you can kill me simply by being around me, then you have a moral obligation to protect me. And I have the same thing to protect you. So with that, well, we now want to move towards what have our people heard, people who are in positions of some authority who have heard. And I'm going to start with Jay, and then I see George's, and hopefully, I'm not sure whether Lori is able to get on or not from NACHO, and Lamont Carey from DC government. Hopefully they are hearing that it is their turn to take the stage. And so we'll see in a moment. But with that, Jay, you are you're in the rocket ship at CDC and talking with the White House people. You've heard a lot of stuff tonight. What are you taking home?
Well, let me start with some of what I've heard over the past 18 months. Like many public health officials, I've heard a lot of threatening talk. Actually, no death threats, but I've had several people tell me I should be locked up. And I think what I heard tonight was a very positive aspect of that. Public health needs to be behind bars. The partnership between public health and public safety has struggled for years, but it is moving in the right direction. As Deanna brought up, there's been a lot of progress over the past 5 years in looking at opioids and the challenge with addictions in the among incarcerated persons. And I think actually that is an example where I've seen people who absolutely did not believe in treating any kind of addiction among people who are incarcerated have opened up to recognizing that there are treatments that are available and that can make a difference. Another issue that I heard highlighted very clearly is the importance of communications. And I think even though, for instance, myself speaking into a incarcerated population would probably have no impact at all, being able to help family members to be able to deliver those messages to loved ones who are behind bars is so critically important. And the third thing is kind of the big picture, thinking back on what Roach was saying about people who get out of prison. And basically are not equipped to be able to re-enter the community. And oftentimes what that means is they wind up homeless. And if they're homeless, how do you survive? Sometimes that involves committing crimes or perceived crimes, which ultimately then leads to reincarceration. So breaking that cycle of incarceration and homelessness is really critical as well. A little bit more of a big picture view, but all of these things are the areas where I believe public health can play a role, and working together, we can make a difference.
Thank you so much, Jay. Thank you. And let me turn to one of my heroes, Dr. Georges Benjamin. Dr. Benjamin is the leader, the CEO of the American Public Health Association. And so I know he has heard this conversation thoroughly. And Georges, what did you hear and what are you thinking about?
Well, we know that from a public health perspective, we need to be able to provide adequate care no matter where people are. And we have created an environment where we have jails and prisons, which are basically, in many cases, have people who have a range of health problems and not being adequately addressed. We've seen this through the many years. And we have to spend a lot more time making sure that we build systems so that those folks get the care they need when they're behind the bars. We know that in most cases, not only do they go in, but they come out. And they need to go in healthy, and they need to come out healthy and reformed if they're committed a crime. But far too often we're used, as you've heard earlier, we've used these places as warehouses for people who really don't need to be there. The reason they're there is because of medical reasons, which have resulted in problems that have resulted in getting behind the bar. And I think that as a public health community, we've got to pay a lot more attention to that. I was deeply disturbed when we got into this big debate about whether or not we should vaccinate people behind bars. We absolutely should vaccinate anyone in a conjugate setting. And there's nothing more conjugate than being behind bars and not having the freedom to make an informed decision. And we had these huge debates, particularly when vaccine was in the early part of it, when vaccine was short. All that does is foster infection. I think the other thing we have to do is make sure that we adequately vaccinate the staff that work there, and find ways to make sure they're adequately covered. Because again, not only do they go in and out of those conjugate settings, but whatever they catch there, they bring home, or what they catch in the community, they bring into the jail.
Thank you so much, Georges. And one of the things that I want to make sure the audience does understand with Jay, Georges, and as I turn to Lori Freeman, is that all the advocates, as I worked with them on producing this show, said over and over again that this population is forgotten and that they just are not on the radar. I think it is very important for me to say that people like Jay and Georges and Lori and Lamont spent 2 hours listening to a conversation on a weekday night, that they care about this and they are putting in the effort. I mean, it's hard to take notes for 2 hours and on a show that moved as fast as this and stayed with it and taking it seriously. And so one of my heroes is Lori Freeman, who is the CEO for the National Association of City and County Health Officers. And I will say this about Lori. Every time that the Black Coalition Against COVID has ever asked anything of her, she says yes before you can get the question out of her mouth. That's how committed she is to fighting this fight. I have such admiration for Lori. Lori, what did you hear and take away from this?
Oh, Reed, I heard so much. A lot of it was distressing, but with everything that we brought up tonight in terms of the needs to really change this system, there's hope as well. NACCHO, that represents the county and city health departments, has long recognized mass incarceration as a mental and physical public health crisis that impacts children and families and whole communities, especially African Americans and Latinx communities. And we know that these devastating impacts affect well-being over a lifetime for individuals and communities. And so I was just sitting here reflecting, what could I say in 1 or 2 minutes? And, I love this idea of maybe we should need a public health official or a public health professional in every single facility in this country, jail, prison, whatever level there is, to ensure that we're taking these public health approaches. And we're not just talking about clinical care here. We are talking about a true public health approach where we consider the person as a whole in their community and how we can get them back to contributing as full members of their community. And lastly, I'll say, to the point about reentry, there are many, many policy things that we can do to help people get back on their feet. These are potentially productive members of their community, and we are missing out on including them and reestablishing them as productive members of the community. And we need as many productive members of our communities as possible. Removing check boxes on employment applications that ask individuals whether they've been convicted of a crime, ensuring that we have stable housing for returning citizens, medical homes for them, eliminating probation policies that punish people for not having stable housing or jobs, taking away and ensuring that we remove these barriers and we repeal any laws that deny formerly incarcerated people from the right to vote, even, and making them less productive members of society. So there's so much more I could say. I know we're at time. I hope you'll invite me back at some point, because I'd love to be able to engage more and talk about some of these.
Oh, Laura, you're perfect as always. And I think at some point, as a follow-up with the advocates that have been on tonight, I think George's and Laurie and Jay, we probably need to have a meeting just to start going over some of these things and thinking about what we can do. Well, I'm glad that we can end the show with another good friend of mine, Lamont Carey. Lamont works in DC. He is in charge of the returning citizens program for DC government. Lamont has been really, really close with us at the Black Coalition Against COVID. I mentioned earlier that we have a DC grassroots component. Lamont, what did you hear that is relevant to the work that you're doing every day coming back to DC from being incarcerated?
Well, it was so much that I heard. One of the biggest things that I heard is that there is a need for corrections to be more engaging with the community. One, our loved ones are incarcerated and isolated, and it's supposed to be a rehabilitation process, right? Supposed to be Department of Rehabilitation. And from the conversations of having access to information, having access to facilities, says that we can't be preparing individuals for successful reentry if we can't even really engage the institution, not just the one our loved ones that are residents there, but being able to engage the institution. So if reentry supposed to begin on the day that an individual is incarcerated, then we are cut out of that process. And I think one of the pushes so that we can be able to identify what the experiences are, what the barriers are that our loved ones are experiencing, we got to demand to be a part of the correctional experience. Now, in terms of individuals, how I think that we could potentially increase the numbers of people getting the vaccine inside the institution is one of the things that Mayor Bowser has done in the district, create incentives, right? So we know a lot of individuals that are incarcerated are disconnected from their loved ones, and the income that they have may be coming from school or the jobs that they have. So maybe creating some kind of monetary incentive to get the vaccine, even being able to get good days added onto your sentence. I'm sure both of them would increase the number of people that are taking the vaccine. And in terms of reentry, I think I could say that DC is sort of progressive in that, but one of the barriers that we do have may be the communication with the Federal Bureau of Prison. But I think when we're talking about getting the individuals vaccinated, definitely the family, because a lot of times in institutions, they hear about what's going on in our community or what is happening in our community before we do. And I also agree that there are shot callers or leaders that can translate the information quick. But more than anything, I think the panels that I witnessed should be inside of these institutions. And you need the variety of races that were on the panel talking to the different groups, because prison is one of the most segregated places that I have ever been in my life as a former returning citizen. And so if you, it was sad to say, if you have a Latino person talking to the Latino group, if you have African-American talking to the African-American group, especially from the African-American and Latino population, I think the voices definitely needed to be heard, to be a motivating tool, because we rarely see African-Americans that are doctors, especially inside of these institutions. And so I think that is one way to help increase the numbers, and just educating the families on that their loved ones can get the vaccine inside of the institution. But one of the biggest things that we are combating in the federal prison, it might be 7 televisions that's on at all times, and the commercials or the news broadcasts that they're seeing is about the increase in vaccines. Right? We witnessed Reverend Jesse Jackson take the vaccine on television and then see that him and his wife end up in the hospital. But we are not seeing more images or stories on those that have gotten the vaccine and that have not ended up in the hospital. And so I think we have to be able to combat all of that, because all of their information is coming from the television, it's coming from the newspaper, and it's coming from the telephone. And if we're able to aggressively attack those by educating them on why they should get the vaccine, I think we can increase the numbers.
Well, perfectly said. We got work to do. Let me thank Roach Brown. Let me thank Jay Butler for being here with us. Let me thank Liesl Hagen and Homer Venters, Ed Hayes, Dan Mistak, Deanna Hoskins, Tracy Gardner, Felicia Henry, Shelley Solomon. Let me also thank Dr. Gigi and Samira Brown, all of you for being here tonight. And then, of course, Dr. Georges Benjamin, as well as Lori Freeman, and also to our good and wonderful colleague from DC. And that's Lamont Carey. Thank you all so much. And thank you to everyone that stayed with us tonight. We know that we put a lot into this show. We have a lot more to do. We've only pricked the surface. We now have to do the work to be able to deal with all the issues that have come forward. The Black Coalition Against COVID and the 4 Black medical schools, the NMA, the National Black Nurses Association, the Urban League, blackdoctor.org. We hear you. We hear you. You are not forgotten. Your plight is not ignored, and we will keep at it in the days to come. Thanks, everyone, for joining us. Please get vaccinated. Please don't listen to Pookie on the internet for your information. Please go to trusted sources. Please, please wear your mask, especially indoors, and especially if you're around people that do not live with you. Protect your children. Don't forget to socially distance. And above all, take care of yourselves. Good night to everyone. Thanks for joining. Bye-bye.